Shukran. First of all, Salam alaikum. I would like to thank Professor Kamal Saro for inviting me over. It's a real pleasure. Now, I'm going to talk about the deep endometriosis. I think that Professor Chapran is talking about the diagnosis. I think that we have to understand some of the how does it come into being, and how to better diagnose it and how to better treat it. Now, this is my disclosure. Now, we know that the three major subtypes of endometriosis, the most prevalent ones probably superficial endometriosis, ovarian endometrioma, and also the deep endometriosis. Deep endometriosis is actually although it's not as common as the other two subtypes, but there's also impact on the patients as the quality of lives more severely. And it is also associated with the adenomyosis, and but in terms of its pathogenesis, we don't know much about it, and there's tons of review papers on deep endometriosis. Now, question is, how does it come into being? So we only need to know its pathophysiology from the intervention standpoint. I think that how to better diagnosis and how to better treat it. Now, I think that it's probably for me to talk about how to better treatment, because we still need a lot of research. But can we actually construct an animal model so we can actually better study it? So one thing is that we take the Chinese proverb says, it doesn't matter, you don't know the thing. You know the thing actually better by comparison. It's essentially, if you don't know anything about the cell phones, you could go to the store, do some other comparisons. You immediately know something about the cell phones. Now, the one thing we did almost 2 decades ago is actually based on the gene expression profiling. And what we did is actually essentially the ovarian endometrioma and non-ovarian endometrioma. It turned out, based on these genetic gene expression signature, we can actually separate these two subtypes. And also, we know that the lesions are fundamentally wounds undergoing repeated tissue injury and repair simply because the ectopic endometrium, just like the utopic counterparts, actually bleeds every month, and so it's a cyclic bleeding, and bleeding is actually a hallmark of tissue injury. So once there's a tissue injury, there's a tissue repair going on, regardless of the organism, and essentially to ensure the survival and the function of the organisms. So with this, we can actually see that based on these repeated tissue injury, we can identify three important molecular processes. One is the epithelial mesenchymal transition. The other one is a fibroblast to myofibroblast transdifferentiation, essentially that generates myofibroblast. That's the very important effector cells for producing collagens and producing fibrosis. And these myofibroblasts, if you actually under a constant stimulation, then they become smooth muscle cells. And that's why you can actually see around the deep endometriotic lesions, there's a lot of smooth muscle cell-like cells. So in this case, we can actually explain things very easily. But the important message is this: actually, the lesions progressively become more fibrotic. So what we first did is actually we characterized the ovarian endometrioma and deep endometriosis. It just turns out that there's different immunohisto features between these subtypes. One is, first of all, that in terms of TGF-beta, the staining in deep endometriosis is actually higher, and also in terms of epithelial mesenchymal transition process, it seems to be more complete in deep lesions as compared with the ovarian endometrioma. And also, the important things, deep mitotic lesions has more fibrotic content and more collagens, and that actually makes them more stiff. And we can actually use this for diagnostic purpose. The other one is the progesterone receptor B is actually was decreased in deep lesions, and also some of the vascularity is actually reduced in deep hematusis. That actually explains why deep hematotic lesions are more resistant to medical treatment, simply because of reduced vascularity, and then it is very difficult to deliver the drugs to the target tissue, which is actually lesions. And so we know that the epithelial mesenchymal transition, fibroblast to myofibril differentiation, smooth muscle metaplasia, and fibrosis actually more complete in deep mitotic lesions as compared with the ovarian hematoma. They also have lower estrogen receptor beta staining and less vascularity, which is actually more resistant to medical treatment. So the question is, what causes the difference? Now, there's lots of papers published documenting, say, the lesions are actually highly innervated, and there's a close histological relationship between nerves and the fibrotic component of the nodules. And so neurogenesis is near the lesions, and the ovarian hematoma lesion is actually rarely innervated. So one thing I suspect that came out of mind is actually perhaps a nerve plays some role. And we can actually think of this. This is actually the old view. That's essentially that the hematotic lesions secrete molecules that actually essentially increase the nerve fiber density. But we can actually think that because the lesion is a wound, it's a physical entity, it's probably like an organ, and it's like a standalone house. So in order to make the house more functional or livable, first of all, you need roads. That's actually a vascular system. You need nutrients and supplies, and also you need disposed garbages. And there's a drainage system that actually you dispose wastes, and that's actually a lymphatic system. And also you have to communicate with outside world. That's actually the nerve system. So in this case, it actually becomes a two-way street. And maybe the nerves actually can secrete new peptides that actually can impact on lesion, impact on their progressions. And in fact, if you steer the anatomic locations of ovarian hematoma and deep lesions long and hard, you understand that actually the deep lesions actually usually are near in proximity to nerve fibers, nerve plexus. In contrast, the ovarian hematoma is actually rarely in proximity to these nerve plexus. So we know that the sensory nerves actually secrete multiple bioactive neuropeptides, for example, CGRP, substance P, and they have their respective receptors. And so we, first of all, we actually did some mouse experiment. We actually chemically denervate their nerves, and then we see how the lesions implanted and how they will fare. And we actually used actually neurotoxins, and then we actually found that yes, indeed, the chemical denervation of sensory nerves generated that the lesions actually those essentially the smallest, followed by the chemical denervation of the sympathetic nerves. So essentially, yes, nerves actually somehow involved in lesion progression. And also, we have to know that these chemicals actually turn out to be NF-kappa B inhibitor. So, and NF-kappa B is also involved in lesion development. So we have to take these results with caution. So we did a second experiment. We actually did surgical sensory nerve denervation, and then we actually used nude mice, and then we actually inoculated human mitotic lesions, and then we actually found that yes, actually if you denervate the sensory nerves, actually the lesion will become smaller, suggesting that yes, indeed, sensory nerves are involved in the progression of these lesions. So then the other thing is actually, this is actually we denervated. What about we use infusions of some of the neuropeptides secreted by these nerve fibers? We actually infuse a solvent as a control. We also infuse substance P. We also used pre-treatment with the substance P receptor, which is a neurokinin receptor 1. And then we see, it turns out that yes, if you infuse the substance P, that will substantially, significantly increase the lesion weight. But if we treat it with the neurokinin receptor inhibitor, actually the lesion will become much, much smaller. And also the lesion fibrosis is seemed to be correlated with these lesions. So, so the phenotypic difference between ovarian metroma and deep lymphosis actually may be attributable to their respective microenvironment. So essentially, the sensory nerve participate in all three major steps: EMT, FMT, and smooth muscle metaplasia and lesional development. So we also did some in vitro studies, essentially that, essentially I just long story short, essentially if you culture these lesions with the substance P, and that would essentially facilitate the epithelial mesenchymal transition and also fibroblast to myofibroblast transdifferentiation, and also smooth muscle metaplasia and fibrogenesis. Essentially, there's a greater production of extracellular matrix products. But on the other hand, if you suppress the receptors for substance P or CGRP, then they can actually abolish all these changes. So with this, we can actually conclude that sensory nerves are actually responsible for the formation of deep lymphatic lesions. So we actually go back. Actually, we actually looked at the human data again. Indeed, yes, CGRP actually increased in deep lesions as compared with the ovarian metroma. And also the receptor for substance P is also increased. And also some receptors for CGRPs, two receptors. And they're also highest expression in deep lesions, followed by ovarian metroma, and then the control in metroma. So this essentially consistent what we actually hypothesize that is the somehow the neuropeptides secreted by sensory nerves is actually involved in facilitating lesional progression by increasing the fibrotic content. So with this, actually, we also can look at if there's any other culprits. And of course, there's also mesenthelial mesenchymal transitions in the sense of the peritoneal mesenthelial cells, which is essentially the thin layer, single cell layer that lining the peritoneum. They can actually become the mesenchymal cells and actually actively participate in lesions, and also the some of the endothelial cells can also become mesenchymals and essentially becomes accomplice in facilitating lesional progression. Okay, and they're also involved in fibrogenesis, and so essentially the natural history is not only the lesion itself, but also its crosstalk with the neighboring tissues and cells, including some of the sensory fibers and some of the mesothelial cells, and also endothelial cells can also be coopted and become mesenchymal cells and contribute to lesional fibrosis. So can we actually capitalize this knowledge to establish mouse models of deep endometriosis? Indeed, actually, that we essentially there's 4 features: adhesions, fibrosis, and also the dense tissues. And we can actually by just the routine common mouse models, but we can add it with the infusion of substance P or CGRP, we can actually make the lesions that actually become very cheap mouse deep endometriotic models. Now, the question is how we can actually better diagnosis. Now, we can actually take advantage of the entire process in the sense the lesion become more fibrotic, so it becomes stiff. That's actually where in gynecology palpation is very important. But palpation can be very effective, but if the lesion is kind of large or actually close to the body surface. But on the other hand, if it's deep or small, it can be very difficult. So that's why the elastography can be very helpful. Elastography essentially is the imaging equivalent of palpation, and there's essentially 2 elastographic ultrasound elastographic available. The one is the string imaging, the other one is the shear wave imaging that essentially measure the tissue stiffness. And we actually use this one to diagnose adenomyosis and got a very nice result. Essentially, the adenomyotic lesion is the stiffest, followed by fibroids, and then followed by the normal myometrium. So for diagnosing deep endometriotic lesions, we actually did some studies and actually found that for small lesions but stiff, the elastography can be very effective to identify these lesions and actually has the highest sensitivity and specificity, better than the MRI and better than the gynecologic examination, and also better than ultrasound. So with this, I think that the conclusion is the formation of deep endometriotic lesions accelerated by surrounding sensory nerve fibers, endothelial cells, and mesothelial cells near or in deep endometriotic lesions also contribute to the lesion fibrosis, adhesion, and nodular formation. And so all 3 types of endometriosis are in principle the one and the same disease, but not necessarily they have the same pathogenesis. But the lesional development actually shapes the tempo and the pace of the progression. So it's just like the mammals in different forms and sizes, and actually they're all mammals. There's actually the monkeys in Japan. They are enjoying the hot springs, and giant panda in China, and also this is actually seal in the Baikal Lake in Russia. They're all mammals, but actually, apparently, the shapes and forms are quite different. So, in conclusion, the formation of deep endometriotic lesions is facilitated by surrounding sensory nerve fibers, endothelial cells, and mesothelial cells. In lesions also contribute to lesion fibrosis, lesion, and nodular formation. And 3 types of endometriosis are in principle one and the same. And we can capitalize all these findings. We can actually build very easy economical mouse models. And elastography can be superior to a conventional ultrasound in diagnosing deep endometriosis. and can also help us to choose the best treatment modality and better treatment. We still have to wait until we do more research. So with this, thank my collaborators and you call your attention to the journal, official journal of SIUD, and dedicated to endometriosis and uterine disorders. Thank you.